everyone, I'm Ella, your host for the 7th episode of IMpatient Ask a Doctor series. Our session tonight is all about women's sexual and reproductive health. We've invited a special guest to answer some of our questions and educate us more on the topic, which is an integral part of women's overall health. With us tonight is Dr. Margaret Joyce Cristi-Limson, a distinguished gynecologist and obstetrician with 10 years of experience. Dr. Limson is the head of the section of Reproductive Endocrinology and Infertility at the Makati Medical Center and is a clinical associate professor for the College of Medicine at the University of the Philippines, Manila. She is also affiliated with Manila Medical Center and St. Luke's Medical Center, Global City, and Center for Advanced Reproductive Medicine and Infertility. Let us all welcome Dr. Margaret Limson. Thank you so much for joining us this evening.
Hi, Ella. Good evening. Thanks for inviting me. So it's a pleasure to be here.
We're thrilled to have you tonight, Doc. And we have a ton of questions for you. And I'm sure our viewers are eager to get some answers.
Time you're ready.
Let's get started. Yes, very exciting. So let's start with the basics, Doc. Periods, which is the monthly shedding of the lining of a woman's uterus to prepare the body for pregnancy. They say that our menstrual cycle can tell us a lot about our health. So having period problems can usually be a sign of health problems, right? So our first question for you, Doc, is when is a cycle considered irregular or when does it become a cause for a doctor's visit?
Okay, so normally we would say 28 days is quite regular, but classically it would be 28 plus minus 7 days. So it was quite easy to remember. So this was when I was in medical school. So that would be a range of 21 to 35 days. But recent guidelines, so the latest will be from Monroe. So this is a 2020 guideline. So they set it at 24 to 38 days. So a cycle starting, a cycle interval from start to start or interval of up to 38 days from start to start is considered quite regular. So that would be regular menses. But this is just talking about regularity, okay, talking about the interval of menses. Okay, sometimes menses can be quite short, no, maybe about 3 to 5 days in duration, but the menstrual flow is quite heavy. So that one is also not abnormal. So, but when do we say it's actually quite okay, or this is still acceptable, not the flow? So it would be individual variation, but I would say anything more than 8 pads per day would be quite heavy. So yeah. And also menses lasting for more than 7 days, heavy flow, no, not spotting, hindi po yung mga pahabol, would be considered irregular. And of course, bleeding in between menses is definitely not normal. So if you're having mid-cycle bleeding or prolonged spotting after your menses, this is not normal. Okay, so for these, these are indications that you would probably want to consult with your gynae to find out if there's any pathology that needs to be addressed. But I believe I always tell patients now, like they skip 1 month of menses, but it's once in their whole lifetime. I believe that maybe once or twice in a woman's lifetime, she might have some irregular menses. But as long as it doesn't recur, doesn't keep happening, then this might not be a cause of worry. So you can just observe this, and if it doesn't happen again, then maybe she was just truly highly stressed out at that point in her life that may have caused some menstrual irregularity.
Okay. It is really important that we pay attention to our menstrual cycle, especially since it's hard to compare our menstrual cycles with each other, no?
Oh, that is very true, no? It is an individual thing, no? So you'll have your certain normal that is just really, truly for you.
Okay. And there are said to be a variety of factors that could affect a woman's menstrual cycle, like stress, lifestyle, medical conditions, and even some medications. But lately, kasi lots of women have been sharing stories of how their cycle changes following COVID infection and vaccination. Our viewers want to know if these two could indeed affect or disrupt our menstrual cycle.
Yes, I think so. Although studies are not there are not too many studies. I came across a couple from UK, and they did say that there are associated COVID infection and those who had the vaccine. So a couple of my patients actually claimed that. So in a patient who previously had very regular menses, and then after the COVID vaccine would present with some menstrual irregularities, and I would advise them to observe this first before
Mhm.
being aggressive in terms of any intervention.
Okay, because I'm sure the vaccine is very important, especially in curbing the pandemic nowadays. So for now, we'll just observe na lang muna, no? And
Right.
another thing that most of our viewers want to know is regarding menopause. So, diba, at a certain point, a woman's ovaries stop producing estrogen and progesterone, marking the end of the menstrual cycle. So we know this as menopause nga. However, lots of women are unaware now of the transition period before menopause, which is called perimenopause. So until they experience it, could you tell us about the changes women should expect when undergoing the perimenopause stage?
Okay, so perimenopause is just like early menopause. So you're right, no? It's a very good description. It is a transition. So normally, the first manifestations of a perimenopause would be menstrual irregularity. So at this point, the hormones start changing, although it's not completely, low. The estrogen particularly
Mm-hmm.
isn't completely gone yet. There are menstrual changes. The usual menstrual change that you would see would be skipped menses, okay, or irregular, infrequent menses. Although it has been documented that some degree of menstrual anomalies, such as heavier menses, can occur during the perimenopause period because cycles are generally anovulatory, meaning hindi nangingitlog yung patient. So cycles are
Mm-hmm.
unpredictable. So like I said earlier, skip menses, but sometimes irregular in terms of heavier menses than before. But before we attribute such type of bleeding, no, the heavy, more frequent menses, we would want to eliminate any other problems rather than just chalking it up to perimenopause. So that would be the usual initial symptoms of patients who are in the perimenopause. But some patients do complain of vasomotor symptoms such as hot flush, no? And some would complain of changes in mood. Medyo mas nagsusungit po. So it's really true, no, that perimenopause time, medyo may mood changes, some decrease in sleep quality, which will become more profound or more noticeable during the time that a patient is truly menopausal or when the ovaries really stop producing estrogen.
Doc, at what age should you start to expect perimenopausal symptoms po ba?
Okay, so let's put the documented age based on studies of menopause pegged at about 48 to 49 years old. So this is for the Filipino. Okay, but in Caucasians, it's usually stated that it's usually the age of 51 years old. So perimenopause can start as early as 1 year before the actual menopause to as long as 5 years before that. Okay, so we consider maybe patients getting menopause at the age of 45 acceptable, no? But anything
Okay.
earlier than that is termed early menopause. So 40 to about 45 would be early menopause. And women who actually have estrogen deprivation or ovarian failure before the age of 40, this is what we call premature ovarian insufficiency. So parang menopause in the young woman. So this one is truly not normal and will have to be treated with some form of estrogen supplementation.
Okay. So you heard it also, Doctora. If you're in your late 40s and you're experiencing irregular and infrequent menses, you might actually be nearing the end of your reproductive years. So now that we know what to expect, some of our viewers want to know the best way to manage its course. So nowadays, nga, diba, there are numerous treatments available to help ease the symptoms, with hormone therapy being one of the most popular options. However, people have been hearing that there are a lot of risks associated with it. So what are your thoughts on hormone replacement to help relieve the symptoms of menopause? Would you recommend it?
Okay, so just a background regarding hormone replacement therapy. So why do we give it, no? If the problem with menopause or the underlying physiology is estrogen deprivation or the ovaries stop producing estrogen. So what we'll want to give back would be estrogen. So hormone replacement therapy is basically giving you back your hormones. the uterus, estrogen alone is fine, is sufficient. But for patients who still have a uterus in place, no, intact uterus, then we would need to give additional progesterone to make sure that the lining doesn't proliferate abnormally. It might become, hyperplastic, or might end up as having endometrial cancer. So it is either in the form of estrogen or estrogen plus progesterone therapy. So that's hormone replacement therapy. Now, back in 2002, there was a big study. It's called the WHI, or Women's Health Initiative. And they embarked on this huge study to determine the effects of hormone replacement therapy. Okay. A year later, they stopped. They stopped the study early because there were findings that those who were using hormone replacement therapy had earlier death. So they
Oh.
immediately stopped that, and sales of hormone replacement therapy crashed. People stopped using it. No,
Mhm.
we were afraid to use hormone replacement therapy. But a few years down the line, they started reanalyzing the data, and they found that the population of patients were generally at the age of about 62. So these are older
Oh,
patients,
okay.
and with possibly underlying cardiac disease
Mhm.
already. So these women are actually not good candidates for HRT. So now, there's a big effort to try to bring back hormone replacement therapy, or to encourage its use, because the benefits a lot of patients will truly outweigh the risks. Okay, so
Mhm.
you're asking me, would I recommend hormone replacement therapy to my patients? No, at this point, the studies are very clear and very robust, and the recommendations for women who need it. First, those are women who have significant or severe vasomotor symptoms, such as a hot flush that's significant. So women will complain of debilitating hot flush. Okay, parang it's too frequent na it's difficult for them to function with that. The second will be for osteoporosis. Okay, can be treatment for osteoporosis as well. And the third can be for patients who have vasomotor symptoms. Vulvovaginal symptoms, or genitourinary syndrome of menopause. So those who complain of significant dyspareunia, or painful intercourse, or vaginal dryness, vaginal replacement, so estrogen. Okay, so there's also this concept, the window of opportunity. So we will only offer HRT to patients first. Okay, of course they need it.
Mhm.
Second will be for those who are within 10 years from the age of menopause and less than 6 years old. So we think at that window of opportunity, giving or initiating hormone replacement therapy will be safe. Okay, so we don't give it to older women. Okay, so we
Mhm.
also choose the patients that we would give or offer hormone replacement therapy to. And it is after a good discussion with the patient that we would actually, we will discuss with them the risks of hormone replacement therapy. Okay, of course, that there's a risk of higher risk of cardiac disease. Okay, for patients who are not good candidates. Okay, so for the older patient, but generally it's considered protective if it is started within the window of opportunity. Okay, and there's also the issue of the risk of breast cancer. So with prolonged use, and there is an association, but we don't know if the association is causal, cause and effect. No,
Mhm.
so if there's an issue, then we just advise patients and discuss all of these issues with them, so that they can make informed consent, no, in terms of informed decision making, whether or not they'll want to use hormone replacement therapy, if it's a therapy that they would want to consider to address their symptoms.
I'm sure some women talaga, it would be beneficial to increase their
Oh,
quality of
definitely.
life,
Yes,
especially if they have yung
definitely.
mga debilitating hot flashes or osteoporosis. I'm sure if it's indicated in the specific patient, or if it would really increase their quality of life, it can be recommended, no?
Oh, definitely. Yeah, in
Mhm.
a properly selected group of patients, it's not going to be a problem, and this will definitely have to be monitored by the
Mhm.
healthcare providers. So, yeah, the thing about Filipinos, no, they don't usually complain of hot flushes. Okay, so matiisin eh. Yeah, and
Mm-mm.
maybe it's also because of the climate here in the Philippines. So, yeah, it's not a usual complaint. But when
Okay.
some women do get it, can be very significant, and it can really, that's right, no, truly affect the quality of life.
Mhm. Okay, so closing on our topic of menopause, since we've covered the menstrual cycle na din, we're gonna move on to our topic of sex, more importantly, safe sex. So protecting your sexual health is an essential part of being sexually active, but most often here in the Philippines, especially, it's overlooked and it's so taboo to talk about it sometimes, especially with our culture here. So because of this, I think the cases of HIV or other sexually transmitted infections and maybe even unintended pregnancies continue to increase throughout the years. So I think it's important that we talk about it here. So many are curious to know also the different ways on how they can protect their sexual health, or when they become sexually active, what are the specific birth control methods they can use, or methods they can use to protect themselves from STIs or sexually transmitted infections. So would you be able to educate our viewers on the different birth control options and what they can consider when they're choosing one?
Okay, so if it's really for prevention of sexually transmitted infection, it would really be the condom. Okay,
Mm-hmm.
so that will definitely protect from HIV particularly, and possibly hepatitis B and syphilis. Okay, but talking about contraception is, of course, basically the premise is not only for protection against sexually transmitted infection, but also the protection from pregnancy if it's something you're not ready to deal with. Okay, but so there are patients who are on the pill. Okay, who are on the pill for contraceptive purposes. But if you are looking at truly protecting yourself from sexually transmitted infection, then it would be the use of a condom on top of that, the use of the contraceptive pill. Okay, and I think also it's a matter of choosing your partner as well. You just never really know. Of course, abstinence is the number one contraceptive method. Okay. Without contact, then you don't get any sexually transmitted infection, and the pregnancy, of course, you won't get pregnant. But I think you're right, no? Discussing contraceptive options is very important, especially in the young population. And it's something that they don't usually, you can't go to your parents and ask, oh, mommy, di ba?
Yes.
Right? So it is important that they are able to get the right information and to choose if they decide to become sexually active,
Mhm.
because I think that's part of responsibility. Okay, and if patients come to the clinic and ask me about contraceptive methods, I do discuss it with them. Okay, I hope you understand I'm very Catholic, but I also believe in
Mhm.
choice. Um, if they are not ready, I think it's more responsible to be on some contraceptive means, no? Instead of finding yourself pregnant and being in that situation when you're not ready to actually be pregnant and to raise a child at a young
That's true.
age. Okay, yeah. So I do promote the use of contraception. So
Mhm.
do you still want me to discuss other forms of contraceptives, but not in the light of prevention of sexually transmitted infections?
Maybe in the broader sense, like maybe if you can ask uh, to choose between either hormonal or non-hormonal, I think there
All
are
right,
natural ways about how we can
that is right.
prevent pregnancy
Okay.
as well.
Okay, yes. So now to prevent pregnancy. So quickly, this is how I would discuss it with my patients. Okay.
Mhm.
So if a patient has regular menses, there's what we call a calendar method. So you just compute. So, but you would need to know your cycles for the past 6 months. So we
Mhm.
subtract 18 and subtract 11 from the shortest and from the longest, and you'll get a window there. So that window will be your fertile window, and
Mhm.
you should not have intercourse during that time. So studies will show that it is quite effective for couples who are very motivated not to get pregnant. So, ibig sabihin, usually yan yung mga patients na, oy, medyo marami na tong anak, hindi talaga magbuntis. But it's quite difficult because the libido is generally higher when during the fertile period. So, yan, again, no, highly motivated couples. So, it also just leaves a small window where you are sure, or safe window na hindi mabubuntis if a couple has intercourse. So of course, there's also the use of condom. If properly used, it might be effective. Failure rate can be about 10 to 20%. Okay, depends on proper use. It's actually quite effective. And again, no, like I mentioned, it is the only one that can truly prevent the sexually transmitted the transmission of sexually transmitted infections. Okay, withdrawal method. Had a lot of patients. Failure of withdrawal method. The failure is about 20 to 30%. Okay, so quite high. Okay, so it's not very reliable. So yeah. So now we go to hormonal forms of contraception. Okay, so basically there would be two hormones. Again, it would be estrogen and progesterone. So a very popular contraceptive method now is the use of pills, so what we call combined estrogen and progesterone. So aside from being contraceptive, it has a lot of medical or gynecologic benefits. Okay, so some patients take it to address polycystic ovary syndrome, so acne, if there's hormonal acne. Okay, some can be used to address pelvic pain or dysmenorrhea, and it can be something that we use to treat or control endometriosis. Okay, can be used for patients who have yan, pelvic pain, who have anemia. So we can also use it to manage abnormal uterine bleeding. Okay, so generally it can be used to related. Okay, I use it a lot. I dispense it a lot. So it's a very good drug that is very important in gynecologic diseases. Okay, so there is also this thing that's called this progestin only pill. So for patients who have contraindications to the with estrogen use, so history of venous thromboembolism or other medical problems that with contraindications to the use of estrogen, then we just give them progestin only pills. Okay, so this is just progesterone. So the thing about progestin only pills is it has to be taken the same time every day to be truly effective. Okay, so pills in general, if properly used, can be perfect use, 97% effective, about 95% to about 90% in patients who with usual typical use. Okay, so a user should know kung kaya niya mag-take ng pills regularly every day. Because if not, then the chance of failure will be higher. Okay, so it's a personal characteristic. So you'll have yourself. And if you keep missing it, of course, then the chance of failure will be higher. So you must consider something that is longer acting. So now we go to the next category of hormonal contraceptives, will be which are called the long-acting reversible contraceptives. Okay, so LARC. So the first amongst them will be the injectable. So that is the depomedroxyprogesterone acetate. So this is progesterone, but it's in a shot. So a woman will get it every 3 months. Okay. So particular for this is we advise our patients to take calcium when they are on the shot. Okay. Because there is documented reversible bone loss. So the bone mineral density will decrease a bit, but once a woman stops using it, it has also been shown that it is reversible. So the woman will regain the BMD again after maybe 6 to 12 months. Okay. So that is a shot. So you have to get it every 3 months. Okay. So the next one will be the implant. So the implant is available locally. It's called the brand name is Implanon. So this is progesterone in a rod. So it's like a toothpick that has progesterone in it, and we slip it right under the skin. No? Yes, that's right. So it's actually a very easy and quick procedure that we do in the clinic. Okay, so yung insertion, it's not a problem really, and then you can keep it for 3 years. Okay, so if you're really looking at spacing pregnancies, particularly for women who just gave birth, I think it's a good contraceptive option. Long-acting reversible contraceptive is the intrauterine device. Okay, so there is one that is non-hormonal. So it's called the copper T IUD, and it's good for 10 years. Okay, so this was more popular yung sa mga lola natin, okay, before they were
Okay.
having children, 8,
Matagal
no,
na pala,
9,
Doc.
10. Matagal na siya talaga, and it was more
Okay.
popular then. And quite effective for long-term use. Okay, so we insert the IUD in the clinic and can keep it there for as long as 10 years. So it's an easy insertion, so not done under anesthesia. And then let's say a woman wants it out after 5 years, and we just pull it out. No, there's a string there that we just pull out. Okay, and then there is another intrauterine device. It is a hormonal intrauterine device. So it's called the levonorgestrel intrauterine system. So it has progesterone. So it's embedded with progesterone. So it's actually very good. We also use it for patients who complain of endometriosis, no, who have pre-malignant endometrial hyperplasia. So it is a good option for patients who need constant progesterone in their body.
Okay.
Okay, so I like that a lot. Use it not only for contraception for my patients, and of course, so for if we're talking about contraception, there will be the permanent sterilization. So for
Oh,
women, it would be the tubal. It will be the vasectomy. Okay, so those are so far the ones that are available here. In the US and other countries, they will have the cervical cap, the cervical diaphragm, and the female condom. Okay, but we don't have them locally.
okay. So it's a very big topic, no, Doc? So
Is
thank you so much for providing us with a very clear and extensive explanation. I believe most women should be informed about the different types because bagay-bagay yan, Doc, diba? So,
right.
different types of contraceptives for different types of women also, since, like you said, for the pill, the woman needs to take it at the same time every day. So what if makalimutin pala yung person? So you can try to choose a different type of option naman, no? So I believe that most women should be informed so that they can choose the contraceptive which is the right fit for them.
Right.
But
So that's a good statement. Choosing something that's a right fit for you, or even between pills. Okay, it would be choosing one that you're hiyang to. So
oo.
it would don't give up on the method just because parang you felt some symptoms. Discuss it with your healthcare provider so that you can find something that you think will right fit. That is the right phrase. Right fit for you.
But I think like what you mentioned earlier, condoms are parang the most accessible and also one of the easiest ways to prevent sexually transmitted infections. No? So aside from using contraceptives to prevent pregnancy, do you recommend using condoms together with the contraceptives?
Okay, so there are women who are on the contraceptive pill to control some medical issue, right?
Mm-hmm.
Like what I mentioned earlier. But if you have a partner that is new, so
Uh-huh.
you're not sure about the sexual background, or if you have multiple sexual partners, okay, then I would still advise to use condoms. Okay,
Mm.
so the pill will not definitely cover for sexually transmitted infections. Now, is the condom good enough to protect? Yes, but if improperly worn or removed too early, and mga ganong issues, or yeah, there are reasons why a condom use would fail, no? Improper use, or may
Mm.
butas yung condom, kung malas kayo, no? Then of course there's a chance for pregnancy. I do have patients who use double just to be super sure, but if there's a new partner, or yeah, multiple sexual partners or high risk sexual behavior, then I would
Mm-mm.
really recommend the use of a condom, with or without the use of any other contraceptive.
Okay. And parang, Doc, diba, I heard it's not also good to use two at the same time. Parang you should only just use one. Tama ba?
What do you
One
mean?
condom, ah.
One?
Yeah, one condom at a time. Not like
Oh,
wear
that is a
two.
new question.
Di ba?
Interesting.
Because
The
they
fit
said
might
parang
be,
some
yeah.
people might use two to be safe. But then I
Oh,
heard also na parang if you use two at a time, parang the friction between both might cause
that is
possible
true. That is
weaknesses.
true. Yes,
Uh-huh.
possibly. And the fit might be affected. So it
Mm.
might not be a tight fit, and there might be spillage of semen, no?
Uh-huh.
Outside. And when you're removing it, no, I can't imagine two. That's
But
new.
I've heard it kasi, Doc, na some people, para safe daw, they'll use
Sigurado.
two condoms at a
Oo.
time. Pero
That's interesting.
I was just wondering, parang, do you think effective ba? Or,
Okay, sometimes the use of like jellies, they
mm-hmm.
would gels, no, they are spermicidal as well.
Okay.
But sometimes you have to make sure because sometimes na the damage din yung rubber ng condom
Uh-huh.
and application of saliva or a woman's nail scratching the
Oo nga.
condom might
Uh-huh.
actually damage that protective sheath.
Mm-hmm.
So those are some of the ways. So improper insertion or too late na yung paglagay or too
Uh-huh.
early pag-alis ng condom might actually cause some spillage canal and cause accidents. Yeah.
Okay. Thank you, Doctor, for the clarification. And especially with all the false information going around about sex and reproductive health, it can be hard to know what to believe sometimes talaga. So for the next portion of our question and answer, we will be debunking some sexual health myths. So let's start. The first myth is you cannot get pregnant during your period. Is this a myth or a fact?
Well, if your menses are regular, then see if you have intercourse during period. Definitely not. If, as a matter of fact, remember we discussed calendar method. That
Mm-hmm.
would be part of the safe window. Just not sure if women will actually have intercourse while they're having menses because it's a bit messy, diba? So,
Oo nga.
yan lang.
Okay.
But yes, that is true. So, the fertile window is generally mid-cycle. So, in a woman who has 28-day cycles, it would be probably pegged at maybe day 10, day 9 to about day 9, 18 to 20, yan. So, unsafe yung time na yon. So,
Mm-hmm.
period will be day 1 to about day 5 or day 7. So, it's generally safe. Definitely. And right before you get your period, a couple of days before, maybe a
Mm-hmm.
5 to 7 day window, that's also generally considered the safe window. Cannot get pregnant during that time.
Okay. So it's for most women, it's very unlikely. Those pero
That
for
is
those with
right.
irregular
It's
periods,
hard to
you just have
say.
to be careful talaga.
That's true.
Okay.
Mhm.
So for the next myth, or maybe fact, urinating after intercourse helps prevent infection. Is this a myth or a fact, Doc?
Um, there are kasi women who have what we call honeymoon cystitis.
Uh-huh.
So they get when they have sex, they will always get an infection.
Mm.
UTI, oo. So that for that population of women, I think it might help. But generally, it's not a necessary thing na, uy, you have to wee so you don't get an infection, no?
Ah,
Particularly
okay.
UTI. I don't think so. But for my patients who do complain of pain or UTI, particularly urinary tract infection after having intercourse. So yan yung tawag nga namin, honeymoon cystitis. Then I
Mm.
would encourage them to try to urinate after if they can, no? After intercourse. So that might help it. And for these patients, we sometimes give antibiotics right after they have intercourse just to prevent that. So if it is
Oh,
really
okay.
documented honeymoon cystitis, not very frequent, okay? So, yeah. For me to say, like, oy, after having intercourse, you have to wee para hindi mag-UTI. Parang hindi naman ganun. It's
Ah,
not
okay.
the usual thing. Mm-mm.
It's not a fact pala. Okay. All my life, I thought that, oh, you have to pee after having
Paano kung
sex
hindi ka
then.
naiihi? So,
Inom
you
ng
drink lots of
tubig, ganon.
water. Oo, then you won't be able
Oh.
to fall asleep. So, paano na yun? Right?
Yeah. Okay, thank you so much for clarifying that. Personally, I really thought that you really also
Ako,
have to pee.
I
Mm-hmm.
never really looked it up, but that's how
Mm-hmm.
I feel about this, okay? So, maybe I will look it up later and see if I'm wrong. But, yun, personal experience also, it's not the case. So,
Okay.
yeah. All right.
Okay. Another myth or fact, you cannot get sexually transmitted diseases from oral sex? Myth or fact, Doc?
Oh, that is a myth. You cannot? Oh,
Cannot.
definitely you can.
Uh-huh.
You can. So particularly HPV, no, human
Mm.
papillomavirus is the virus that causes cervical cancer, rectal cancer, can cause esophageal cancer.
Oh,
So how will
okay.
it get there? So it will be through oral sex. Herpes is also a sexually transmitted infection that can be transmitted. So yan yung mga ulcers. Okay,
Mm-hmm.
so HSV2 from the genitals can be transmitted orally. So that is definitely a myth.
Myth.
Okay?
Okay.
Yes.
So many sexually transmitted infections can be
A
transmitted
couple, some.
orally. Mhm. Okay.
Oh,
So are
wala.
there
Oo.
ways to make it safer? Like, can you use condoms? Will that prevent it completely or no?
Uh, so basically, sexually transmitted infections, they are transmitted through the fluids and by
Mm-hmm.
physical contact. So as long as you prevent that, then of course, uh, in theory, it shouldn't be transmitted. So I'm not sure if kung nagko-condom habang ano,
Yeah.
I'm really not sure, but
Mhm.
like I said, no, saliva in itself can break the barriers
Oo nga
of
pala.
the condom.
Mhm.
So there can still be some transmission of fluids, deposition of fluids in the oral cavity. So might not be completely safe.
Mm, okay. Another myth or fact. People in monogamous relationships do not need to get tested for STDs. Is this a myth or a fact?
I think it is a presumption. So how sure are you that you are in a monogamous relationship? You are sure that you are
Oo nga.
faithful, but how about your partner? So the
Mm.
thing about some sexually transmitted infections, we don't know yung timeline and sa kanilang development. So let's say I see a patient who's in a 5-year monogamous relationship,
Mhm.
and then we find warts or we find cervical cancer, and the husband and or the couple, the male and the female, profess that they never had any relationships outside their monogamous
Mhm.
relationship during the time they were together. So for all you know, it was an infection that came from a previous partner many, many years ago. Okay? So cannot guarantee. So when we see patients with warts, sasabihin nila, awayan na kagad yung asawa nila or yung boyfriend nila. They assume
Uh-huh.
that it's from their partner because they claim that they have been faithful the whole time. And the partner will also say na walang iba, ikaw lang. But how about the previous their previous partners. So they may have gotten it from there. So the question whether or not they have to be tested, I think they have to. There's no such thing as regularly testing for sexually transmitted
Mhm.
infection. So let's put a bit. We would test if a patient is symptomatic or if a
Okay.
patient has high risk sexual behavior. So unless a patient has symptoms suggestive of sexually transmitted infection, I would generally not consider testing.
Mhm.
But if in a patient, even in a monogamous sexual relationship, has symptoms, o meron siyang nakakapa sa baba, meron siyang discharge that is suspicious for sexually transmitted infection, then definitely we will test, no, whether or not in a monogamous sexual relationship. So the other thing, no, a form of testing, is pap smear is a test for cervical
Oo nga pala.
cancer. So but this is something that we would recommend to patients,
Mhm.
monogamous or not, as long as the patient is sexually active. So usually by the age of 25 we would recommend this for sexually active women. So it's not really a test for sexually transmitted infection, but it is a test for cervical cancer, which is
Mhm.
a disease that is brought about by a sexually transmitted virus, which is HPV. Mm-mm.
Doc, how often are we supposed to get pap smears again? Just so that we can use this time to educate our viewers
All right.
also.
So, how often, no? So
Mhm.
if there are different types. No? Before it was the slide base, no? So if very, that old school yon. So that would be the pickup rate isn't as good as the newer one. So for these patients, we would probably still consider testing yearly. But for patients who use the liquid based, okay, it would be 2 to 3 years. And if a patient uses liquid based with the HPV genotyping, then it could be the patient can be tested every 5 years. Yeah. So it will be dependent on the type of testing that is done for the patient.
And Doc, while we're on the topic of cervical cancer also, right? The HPV also has a vaccine, if I'm not mistaken.
Right. Yes.
Mm-hmm.
So for age group as early as 9 years old, freaky, no? 9 years old, nagbibigay ka ng
Mm-hmm.
cervical cancer vaccine can be given. So it's a vaccine that's given 3 doses in 6 months. So yun, it's not a cheap vaccine. Okay,
It's
so
not cheap.
it's
Mm-mm.
not. No? So basically, the goal of that vaccine, so HPV, so it will cover basically the two major causes of cervical cancer. So there is actually there are three types of vaccines that are available. So first is Cervarix, no? So it covers the two cervical
Mm-hmm.
cancer causing vaccines. Gardasil 4 will cover the same two, and then we should also have coverage for the two most common wart-causing strains. And there's
Okay.
also HPV 9, which will cover the same four plus the next five cancer-causing. So mas malaki yung coverage. That it
Oh,
comes with the
okay.
price. Okay, so mas
Of
mahal na siya.
course, mas mahal
Yeah.
nga.
But even for patients who are vaccinated, we still do recommend the cervical cancer screening in form of pap
Mm-hmm.
smear.
Still
Okay,
pap
so it's not a
smear.
guarantee. It's just like COVID. We
Uh-huh.
give the vaccine, but doesn't guarantee you 100%, but it will decrease your chance of getting the
Mm.
disease. Yeah.
Okay. Thank you so much for that information on cervical cancer and HPV and also pap smears. I think lots of Filipinos aren't aware that pap smear is a regular screening test that needs to be done, no?
So as a matter
Um,
of fact, for all diseases, no, it is actually
mhm.
really just cervical cancer that has a true and a good
Screening.
screening test. Yes,
Mm.
which is the pap smear. Yes.
Okay. So, our next myth or fact is hormonal contraceptives can cause infertility when used for a long time. Is this a myth or a fact? No.
No, we don't believe so, no? So as a
Mhm.
matter of fact, I know you guys know of some friends who after missing one or two pills, no, get pregnant. Well, even, 'di ba? Allegedly being on the pill. Okay,
Mhm.
so it doesn't make you infertile. Okay, as a matter of fact, that's a common question that is asked. Okay, so some indications where we give pills will be like polycystic ovary syndrome.
Mhm.
Okay, and baseline, these patients are at risk for infertility. Hindi kasi sila nangingitlog.
Okay.
So let's say we see a patient who has PCOS, we diagnose as having PCOS, we give pills to regulate their menses. And when they stop the pill, wanting to get pregnant, they say, oh, I'm not getting pregnant. So is it because of the long-term use or the use of the pills? No, it's because of the underlying
Mm.
polycystic ovary syndrome. So it's not because of the pill use. So in the same way, if we give the pills for to patients who have endometriosis, it's the same thing. We give it for control of symptoms, but after they use it, no, trying to get pregnant, sometimes the symptoms come back, the cyst comes back, and there's also associated infertility. So it's not really the use of pill per se
Mhm.
that is, or the hormones per se that causes the infertility. As a matter of fact, there is sometimes, no, for patients who have irregular menses and who have anovulation, who do not respond to usual modes of what we call ovulation induction or yung pampaitlog, we
Mhm.
suppress them by giving them pills. So it's the irony, no? You give patients who are trying to get pregnant, we give them pills to somewhat suppress their androgens. And then off the pill, we give them the medications to try to make them ovulate, yung pampaitlog. So, so it actually helps, no? For in some cases, if it's used that way. So that is definitely a myth.
Myth.
Okay, a
Okay.
myth. Yes.
Okay. Thank you for clearing up that confusion between use of birth control and infertility, which actually brings us to our next segment, gynecological disorders and fertility. So, gynecological conditions affect the female reproductive organs, and there are actually a lot of different types, but we'll focus on one of the more common ones, like polycystic ovarian syndrome, which you mentioned earlier, or what we call more commonly PCOS. No? So, it is one of the causes of female infertility here in the Philippines, with about 4.5 million Filipinos living with it now. So, what would you say are the major factors that cause this? Is there something that women did, or is this like a genetic thing that predisposes us for PCOS?
Yeah, I think it is something that's genetic. They even
Mm-hmm.
say it's starts developing when you are inside your mom's womb. So
Oh,
there are some, yes, okay. So you have that predisposition already, the outset. Okay, so it is generally a hormonal issue. Okay, we think that the underlying pathophysiology is insulin resistance with compensatory hyperinsulinemia. So the insulin levels rise, and that's what
Uh-huh.
causes the abnormalities in the hormones of FSH, LH,
Okay.
bringing about all the menstrual irregularities, acne, high androgen levels manifested as hirsutism, and again
Mm-hmm.
acne, so and infertility. So yun. What's your question? I forgot.
I was asking if what are the factors that cause this? But yun
Okay.
nga, you said it was mostly genetic nga, no?
No, hormonal
No,
as well.
hormonal
Yes.
also. Yeah.
Mm-mm.
Okay. So, what are the common symptoms you should watch out for? You mentioned hirsutism, insulin resistance ba to? Or
Mm.
mm-hmm.
Okay. So to actually for us, no, when a patient comes to see us for irregular menses, that is
Mm-hmm.
the first symptom that
Oo
we
nga.
we look at. So there's actually a criteria for us to be able to diagnose the patient as having PCOS. Okay. First is menstrual irregularity or anovulation. Hindi nangingitlog yung patient.
Mm-hmm.
Okay. So that is manifested as irregular menses. Most of the time, it would be skip menses. Okay. So intervals more than 35 days. So yan. But there are patients who come with more frequent and heavy bleeding. We still end up diagnosing them as having PCOS. So can be both ends of the spectrum. The
Mm-hmm.
second will be signs of hyperandrogenism. So I mentioned this earlier. So mataas yung male hormone dun sa body ng lady. So it manifested as acne. So yan mga hormonal acne. And medyo mabuhok yung patient, hirsutism. Okay?
Mm-hmm.
So more hairy in areas where males are usually hairy. Okay? Yung like the back of the legs. Okay?
Mm-hmm.
Very excessive dito. Tsaka minsan dito rin. Okay? So very hairy. So we grade this using the modified Ferryman Galway scoring. Okay, we have this,
Okay.
yeah. Okay, and then the third one will be PCOS morphology on ultrasound. So very lot of follicles, small follicles in the ovary, one or two ovaries. Okay, so for us to say that the patient has PCOS, you should have to fulfill two out of the three criteria. So let's say a
Okay.
woman on ultrasound, incidental finding, PCOS on ultrasound, but no menstrual irregularity, no acne, no hirsutism, and then we decide to investigate for high levels of androgen, negative. Then this patient does not have PCOS. It's a syndrome. This patient may
Okay.
have polycystic ovarian morphology, but may not have the syndrome. Okay, so
Mm.
that's completely different. Yeah.
Okay. So, for our viewers, if you're feeling one of the symptoms mentioned by doctor, maybe it's time to schedule a checkup so to confirm if you actually have PCOS with your OB-GYN.
So the other
So,
thing
mm,
pala, yeah, no? So the patients, a lot of our patients, well, particularly a lot of my patients with infertility, yon.
mm,
So that is the end, manifestation of anovulation. If hindi nangingitlog, then hindi pwede mabuntis.
oo
So
nga.
these patients are infertile. So you also mentioned about insulin resistance. So that's one thing that we will check. So if we have a
Mhm,
suspicion that the patient may have PCOS, we check the sugar levels of these patients. So we ask them to do the glucose tolerance test,
mhm.
fasting and sugar test post intake of a sugar solution to see if the body handles sugar normally. We also check the cholesterol to check if the patient has dyslipidemia. So yeah. And
Okay.
sometimes we do check for androgen levels of these patients as well.
Also. Okay. And Doc, you mentioned earlier that most people with PCOS take birth control pills because it helps them regularize their cycle. Are there other ways to reverse or to manage PCOS without medication?
Definitely, yes. So
Mm-hmm.
one thing that we have to tell our viewers, first line management of polycystic ovary syndrome is actually lifestyle modification.
Okay.
Yes, so that is the number one and the first thing that has to be. We prescribe the pills, we prescribe like maybe cyclic progesterone or ovulation inducing medications. But remember, the underlying pathophysiology is potentially high insulin levels because of
Mm-hmm.
um so we'll have to get to the bottom of that, right? So it would be a healthy lifestyle, potentially decrease the sugar levels in the body, And there are truly significant improvements we see in our patients who lose some weight. So what would be significant weight loss? So for patients who are a bit on the heavier side, maybe about 5 to 10% of weight loss in about 6 months is considered
Mm-hmm.
good progress. And for my patients who are on the pill, okay, I give pills for control of for mens to regulate their menses. I would consider discontinuing the pills if they have achieved that level of weight loss,
Weight
because
loss.
sometimes in-expect ko nag-reset na yan eh, and maybe improvement based on weight loss alone and their lifestyle modification is good enough to already bring about control of the symptoms of PCOS. But mind you, do I believe that PCOS can be truly cured? Remember, I
Mm.
said that it might be, it's an innate susceptibility already. It might be a genetic predisposition. It's just an underlying thing that's just there. So if you start gaining the weight again, then the symptoms will
Mm-hmm.
come back.
That's
But
true.
it can be controlled. Okay, cured, probably not. Okay, we give medications to control the symptoms or to address the symptoms of these patients. But you can control it. But if you let go, then the symptoms might come back, and then you'll be manifesting with symptoms of PCOS again.
Okay. It's nice to know that lifestyle modification is actually one of the first things you can try, especially if you have PCOS. So
Yes.
another question is about endometriosis naman, Doc. So it's one of the leading causes of infertility. So could you explain what endometriosis is and why it's so difficult to diagnose?
Okay, so endometriosis is the presence of endometrial glands and stroma. So the endometrial lining. So this is what we shed in a monthly basis as menses. So sometimes this endometrial lining, glands and stroma, no, there's this retrograde menstruation flows through the tube and goes to the pelvic cavity. So it can go to any part in the
Of
pelvis.
your
So the
body. Mm-hmm.
yes, okay, abdominopelvic cavity. So the ovaries would be the primary site or the most common site of endometriotic lesion. So they manifest as endometriotic cyst. So the cul-de-sac or the most dependent portion of the pelvis is the second most common site. And anywhere can be, pwede nasa bladder, can be in the surface of the uterus, can be in the appendix, can be in the bowels, no, can be in the lungs of a patient as well. So, so it can be, different parts of the body. So endometrial glands and stroma, which should not be there, present in ectopic sites, no, sites outside the uterus. So when a patient menstruates, so there's some inflammation, namamaga din yung parts na yon. So usually patients will complain of pain, okay? So in the abdominal pelvic cavity, this will manifest as dysmenorrhea most of the time. And why? So you said it's a bit difficult to diagnose, okay? So we believe that there will be some form of normalcy, no, in patients having pelvic pain or dysmenorrhea when they get their menses.
Mm-hmm.
'Di ba? Parang we accept it. Talagang
It's normal.
nagdi-dysmenorrhea. It's normal, right? So, depende yung threshold mo to believe that this is still acceptable before you actually consult a doctor na, hey, this is not really okay anymore. I'm missing school. I don't go to work. I have to take pain medications every month. So, maybe that's something more. So, the patients I see in the clinic, ganyan ang usual course nila. At first, kala nila okay lang, because it's normal. But then it's getting worse. No, they are debilitated for 2 days. Yeah, can't get up. No, can't go to work. Can't study. So this is definitely something that has to be explored. And then sometimes, no, the thing about endometriosis, it is something. It's a diagnosed surgically. So we need to get a biopsy to be able to definitely say that the patient has endometriosis. But there are patients that we see when we do our physical examinations or on ultrasound, makita na may endometriotic cyst, and we think that these patients have endometriosis. So I do treat some patients who I consider as having endometriosis as endometriosis suspects, and I give them a trial of
Mm-hmm.
medical therapy. And if it improves, then I think that they do have endometriosis and continue treatment with them in a manner that's, using medications that are acceptable.
Okay. So thank you for clearing that up and educating us on a topic that is not most commonly discussed. So another thing people would like to talk about is infertility. Since you specialize in reproductive endocrinology and infertility, more couples nowadays are having trouble conceiving and considering fertility treatments, but they're not quite sure what type. I think now the most common ones are the ones we hear the most are in vitro fertilization or IVF and sometimes intrauterine insemination or IUI. So what are the difference between these two types and which one is most commonly used here in the Philippines though?
Oh, so it will depend on the reason why a couple has difficulty in getting pregnant. So
Mm-hmm.
that's the first thing that we have to identify before we are able to offer any form of treatment. So there will be levels of treatment. So there are some who will get pregnant with just plain ovulation induction. So we will give them the fertility pill. Now there are patients who are candidates for intrauterine insemination. So that's what you were asking. So
Mm-hmm.
intrauterine insemination is pushing in the sperm, okay, into the uterus. So we use a fine catheter. So if we
Uh-huh.
think the lady will ovulate, we use a fine catheter, aspirate the processed sperm, about 0.4 ml of that. So to get the good moving sperm, okay, then push it in para konti na lang yung ilalangoy nila to meet up with the egg. Okay, so that's IUI. So the male produces the sperm outside, so collects it, and then the semen is processed to just get good moving sperm and deposited inside. So
Mm-hmm.
everything, the fertilization takes place inside the woman's body. So yung deposition lang yung yung done outside, no? Okay. IVF, on the other hand, is the highest level of treatment that we offer patients who have infertility. Okay. So basically the concept is we make a woman we give medications to make a woman to stimulate a woman to have ovarian hyperstimulation. So instead of just one follicle growing that will contain one egg, we make a patient we hyperstimulate them, so we
Mm-hmm.
make them produce or have more
Multiple.
follicles, multiple follicles. We induce the growth of multiple follicles, so we can get more than one egg in a cycle. Okay, so after that, so when there's a good lot or properly sized follicles, we trigger and then we get the eggs. Okay, surgically. So under ultrasound guidance, we poke transvaginally and then we access the follicles and retrieve the eggs. So that's a procedure called egg retrieval, oocyte pickup. Okay. And then the same day, the husband will produce sperm, collect semen. Okay. And then the sperm will be um, isolated and then there will be fertilization and the fertilization takes place in the lab. Okay, and then the embryos of fertilized egg, that's called an embryo,
Mm-hmm.
will be cultured outside the human body, so in the lab pa din. So we watch it grow 3 days. Sometimes we freeze on day 3, sometimes we extend the culture to day 5, and we consider transferring if it's going to be a fresh transfer. So put back that embryo, buo na yon, no? Life na yan, fertilized egg na yan. Put it back inside the womb of the lady, or if it's a frozen transfer in the next cycle, then we will put back the embryo. So we get the egg, we get the sperm, put them together in the lab, then allow it to grow for a couple of days, culture it outside, no? So in the lab, and then put it
Mm-hmm.
back, nabuo na. Then we pray and hope that the embryo will implant. Okay, so that's a big difference.
Mm-hmm.
Okay, so for which the number of patients who use it, so it will really depend on the center, the types of patients that they will see, who will qualify as have needing just maybe potentially IUI, or there
Mm-hmm.
are those who will outright need to do IVF. Do IVF, and there are some patients who have infertility who don't need both yet. So there might be simpler treatments, treatment options before considering those two infertility treatments.
Connected to that, is there something women can do to boost their fertility, like health habits wise?
Oh, healthy lifestyle,
Mm-hmm.
definitely. So in terms of smoking, that's a big no-no.
Mm-hmm.
Yeah, definitely. It damages the cilia of the fallopian tube and the motility of the sperm to some extent. Okay. Excessive drinking, of course. So basically, it would be healthy lifestyle. Will always promote
Okay.
good health and
Fertility.
good reproductive health as well. So
Okay. And another topic that is egg freezing. Parang uso siya nowadays, especially with some celebrities. And Some couples or even single women are considering freezing their eggs. What do you have to say about this method, Doc? Is it done here in the Philippines? When should a woman consider it po?
Um, it is done here in the Philippines. So all the IVF centers is very similar to in vitro fertilization or IVF. It's just short of fertilizing. So
Uh-huh.
the women go through the same process. We hyperstimulate them to get as many eggs as we can. But instead of fertilizing that, kasi in theory, kaya nag-egg freezing kasi wala namang sperm available. Then we just freeze them, right?
Okay.
So yun, it is available. It is something that a bit more awareness, okay? So understand that worldwide, the age of childbearing is shifting from younger
Mm-hmm.
age to older
Not
age women.
overage.
So it's also because of career, women are already, you know, prioritizing their career in their earlier reproductive years, and then trying to get pregnant when they're more financially stable, and of course when they find their lifelong partner. So
Mm-hmm.
sabi mo your parents, maybe they got married in 20s. Now it's more common to get married in the
In your
30s, right?
30s, yes.
Right. So that is the age of 35 is already considered advanced maternal age. So that is
Mm-hmm.
the age that we try to beat. Okay? So yon. So uh in a we do offer egg freezing for patients who are interested. No, I don't encourage patients who are too young because it is not very cheap. No? And there's
Mm-hmm.
a chance that they will find their lifelong partner and then not use the eggs in
Oo
the
nga,
end.
sayang din.
Sayang din. But for some people, hindi naman nagmamatter yung money. And for them, that the assurance of getting potentially childbearing in an older age is very important. So this is something that they will like to spend on. So we respect that, of course. But of course, you have to understand it's not a guarantee. Okay, it's not a
Mm,
guarantee. It will just give you that for some sort of security. It's never 100%. Okay, so for generally studies would say to guarantee one pregnancy you would want about 16 eggs, so that's a lot. Okay,
oh,
you
it's
would
a
want
lot.
to free 16 eggs. If you have 5, it gives you the chance, but it doesn't guarantee you of a pregnancy in the future. So yon. Okay, so
Oh,
studies would say a good age would be 37, but personally I think that's too old.
mm-hmm.
So yan. We
Okay.
do offer to patients who have cancer, okay? Because
Oh, okay.
treatment with chemotherapy or radiotherapy can decrease their ovarian reserve significantly. So we do offer it to these patients before they undergo cancer treatment. And this is something that's very important. And I think the
Mhm.
population really needs to learn about that there are fertility preservation techniques, and it's we have the society, it's quite young, but it's very important that we give cancer survivors a chance
I'm
for
sure.
for the reproductive plans in the future, especially those with good those with good prognosis. So we can preserve your fertility. Egg freezing is one of the methods that we offer to patients who are in the reproductive age.
It's nice to know that especially cancer patients can be given the chance to get pregnant also in the
Oo
future, and
naman.
that technology nowadays allows it, no? Ang galing lang talaga.
Yeah, and that it's available here in the Philippines. Hindi
Mhm.
tayo huli in terms of that, really not, no?
Okay.
So the centers here in the Philippines are progressive and I think equivalent or just as good as centers abroad.
That's so nice to know, Doctora. And now we have a few questions from our live chat.
Mm,
If we'll be answering a few of them. So
sure.
first is, what is the recommended contraceptive pill for breastfeeding moms, Doctora?
Okay, so breastfeeding moms should not be
Mhm.
given contraception that has estrogen. So hindi pwede yung mga combined oral contraceptive pills. So
Okay.
anything that has progestin. So again, the options would be progestin only pills, okay, which will have to be taken the same time every day.
Mhm.
So if you're not a good pill taker, considering using the DMPA, the injectable, or if you are looking at something longer term, the implant, which will
Mhm.
cover you for 3 years, or even potentially consider using the IUD. So
No.
nothing that contains it's something that does not contain
Contain
estrogen.
estrogen.
Yes.
Okay.
Because estrogen will decrease the quantity and quality of the milk. Okay?
Okay.
Yeah.
All right. Thank you for answering that. Another question is it true that if you get your period early, you'll also reach menopause early?
No. So that's a common
No?
misconception. So myth yan, okay?
Mm-mm.
So menopause, the age of menopause is genetically determined, okay? Predetermined. So it doesn't matter if you get it at an earlier age. So I would ask patients if they ask me, Doc, when do you think I will get my menopause? Kasi I had my menarche at 12 yun, or
Mhm.
10, medyo maaga. So, mas maaga maubos yung eggs, no? So, no, I tell them, you can ask your mom how old she was when she got her menopause, or if you have an older sister. Because
Mhm.
we would generally say, as long as hindi surgical menopause, and that would be around the age that you will probably have your menopause as well.
Okay. Thank you so much, Doctora. And I think that's all our questions for today. And that wraps up today's episode. Thank you so much, Doctora, for sharing your knowledge and expertise on women's sexual and reproductive health. Before we conclude, do you have any final words for our viewers, Doctora?
No, I think during this time, healthcare
Uh-huh.
has been more accessible. Okay,
Actually.
yeah. So I have patients from places na hindi mo magko-consult sa akin kung walang mga teleconsult and all of that,
Mm-mm.
no? So I have patients from the provinces or even from other countries who actually call for consultation. So it's not very difficult. Now, I know our society can be a bit, our society is reserved, okay? Very
Mm-mm.
conservative, okay? But you should be able to discuss issues with a healthcare provider, especially if you're unsure, to be able to make proper choices.
Mm.
Okay, so if our population is generally the younger people, don't get me wrong, I'm not encouraging premarital sex, but I do
Mm.
encourage being responsible, and that's very important to me. It's very difficult if for me, I see the pain of patients who are pregnant and they're not ready to get pregnant, and in my mind, parang sana they were given, they were educated in terms of their contraceptive choices before they started engaging in
That's
sexual
true.
relations. Or patients who are young patients who come and consult for sexually transmitted infection, and the effects can be multifold, no? Marami yan. Pwedeng magkaroon ng infertility, recurrent HSV infections, and even cervical cancer.
Mhm.
So I think it's proper to arm yourself, no? If you have get the proper knowledge and consult if something that yeah, I think it's important to be responsible. Yeah.
Thank you so much for adding to that knowledge and arming us, Doctora. So our session tonight addressed so many questions that women are afraid to ask. But we would still like to remind everyone that some of the things discussed earlier may not be applicable to all cases. So, like what we mentioned, it depends on the person, it depends on the case. It's always best to consult your specialist or your doctor before making these decisions. So, before we end, we'd like to invite everyone to register on IMpatient by going to www.impatient.ph. For those who would want to consult with Dr. Limson, you may find her profile on IMpatient. Again, it's www.impatient.ph. So thank you, Doctora. Thank you so much once again. I'm Ella Tanka, your host for this month's Ask the Doctor episode. Let's talk about sex, baby. See you in our next episode.